We wanted to also invite both John and David to come back up here because it could very well be that you guys have questions from earlier you didn't get a chance. So, guys, what kind of questions are still on your mind from things today?
Just talking about comorbidities and choosing antidepressants. So I've often seen Prozac or Zoloft be prescribed for somebody who also has anxiety. But I used to see Wellbutrin being prescribed for somebody with ADHD, but I don't know if that's being done anymore. And I was wondering about that.
Yeah, so the question was about comorbidities, anxiety, seeing sertraline or fluoxetine used a lot, but then Wellbutrin with patients that have depression and ADHD, and if that's being done still.
Yes.
Yes.
So the evidence isn't really great that Wellbutrin treats adult attention deficit. However, under certain circumstances, you need to explore non-controlled options before trying a controlled substance. So Wellbutrin is a first choice in those, or in folks who haven't tolerated psychostimulants. So, yeah.
I have an integration question. So many of us in the room here are nurses that have behavioralists available to us, and I often wonder, where do our roles overlap and when should we be handing off versus when is it something that we both could manage? And it's kind of the same with some of the clinical pharmacists with chronic disease management. Is there any practice solution? Do you have a behavioralist in your... Well, it's a little different because you're coming from the other side, so I'd like to...
Right. There are embedded psychiatric nurse practitioners on each of our treatment teams in the primary care setting, and they also have 2 licensed clinical social workers who do brief therapy and other behavioral interventions, and it's a great question.
So you're still not using RNs?
Pardon me?
Because an FNP has prescriptive authority, so it changes her relationship.
True.
And the
Yes.
social worker has a different set. So
Yeah. Right.
You don't have RNs in your setting, then that would be...
In the
it's like we have
specialty
team
behavioral health
RNs.
setting, we do. And in fact, one of our psychiatric nurses is here today. Brenda, maybe you could give an answer to this question. Or actually, I should say that Brenda and I are actually in process right now of trying to better define that question, which is, and especially in context of our integrated health and recovery team, that's the iHeart treatment team that David referred to. And Brenda works with that team, and we're in the process right now of trying to sort of suss out what is a nurse's role versus or in conjunction with the other members of our team, which include a case manager. We have a lot of sort of specialized on our treatment team, and also in the context of the primary care treatment team, where there's a health assistant. They actually have, as I said, a psychiatric nurse practitioner, and so I don't know that I have any great answers for you right off the bat. Sometimes, actually, right now, it seems like it's a practical consideration. Who has the most time, right?
Yeah.
So,
Well, if you can cross-train, I mean, I guess for me, when we, and you will remember this,
Yeah.
we kind of did this new access model to bring in, and so you have a whole morning of new patients, and there was we did a lot of process improvement about, well, the nurse is going to go in, but then if we identify something, then instead we'd use the clinical pharmacist, and there were a lot of areas that overlapped, which is kind of the direction I'd rather go, is like many people are cross-trained, and people identify them as being able to intervene, and then it just becomes time, but I still feel like there's some things that our training better suits us for, and for me, I still want to stay within the scope of my practice and give the patient the best service.
Yeah.
So knowing when that handoff would happen or what to look out for, it would be important for me.
I don't think I have a good answer either. I don't have a lot of primary care experience, but I mean, I think that it's not a bad thing that you're all cross-treating, overlap. I think it comes down to maybe when you feel is out of your comfort zone, like you said, out of your scope of practice. If you're identifying that someone's suicidal and you don't feel like you have the tools to deal with what more questions you can ask, and you have someone at your availability, go around them.
one of the other concepts.
Crisis is
Yeah.
kind of a little easier. Black and white.
One of the other concepts of team-based care, which is what we're emulating with our integrated health and recovery treatment team, team-based care from the primary care setting to, and with all of its kind of current health reform concepts, right, where Like the work of your day is not your schedule, it's the health of your population. That's a team-based care concept. We're applying that in the behavioral health setting. Another concept is that everybody works at the top of their licensure and the top of their skill set. So you don't have providers faxing, right? You don't, because actually I'm terrible at it. I break the copier every time, right? So, but also nurses, at least in my understanding, y'all correct me if I'm wrong, experts in assessment and case formulation and treatment planning, and experts on medication administration, assistance, adherence, teaching, both to people who take medications and people like some of our clinicians who deliver medications to people. So that will inform what we do. Sort of top of your license, top of your skill set, top of your interest as well. So, yeah.
So I guess the other perspective that I think of is how is my staff going to understand who to find, who to go get,
Good
and
point.
what are their options? And
Yeah.
that is a different, completely different conversation than speaking among our professions.
Yeah, yeah.
You know, it could just come down to like, kind of like a working budget, make a little flow sheet. This happens, go to so-and-so, and it can
Yeah.
change.
We do workflows in
Yeah.
team-based care, right? I'm
Well, I
sure
hope
that
you
many
keep
of
us
you
up
all
to
are
date on
doing,
your
yeah,
progress.
very defined workflows,
And
yeah.
have a
A
great
great question, yeah.
So,
Who's next?
me.
All right,
Outstanding.
yeah.
I have a question for David.
Oh, okay.
In your closing, you said to try to ask the right questions. And looking back, what questions do you wish had been asked of you, or what questions really stood out as being very helpful?
That is a really good question. I mean, like, so if the person comes in and they're not malingering or you know, pulling something, in my experience, and that's really all I can give you, is through my eyes and what I've seen. I've been triaged lots of times, obviously. I'm not going to really tell you the truth. I'm going to lie to you when you ask me specifics. When you say, "Are you feeling suicidal?" I'm not. No. Okay, well, have you seen a change in your eating pattern? You start asking symptomatic questions at that point, and I tell you, by the third question, I'm going to just start telling the truth. It's not. It doesn't even matter what the questions are. At that point, it's breaking down to where I can get a rapport with you, because I don't know you. And when I walk in, it's hard to say, you know, like I said, from personal experience, for instance, walking into an emergency room and saying, you know, I haven't slept in 2 nights. I cannot stop thinking about hurting myself. And I'm scared now. And I really don't think I'm safe to be by myself. I was treated like excellent. They were wonderful at OHSU, and questions I guess I wish they would have asked was, do you have a history of substance abuse? Because at the time I was stone cold sober when I walked in, and that didn't get asked. I don't know if my current addiction is just being dry doesn't mean that you're not addicted. I don't know if that played into it, if not being in recovery but just being dry made a difference. I know that since the iHeart team started, I've just seen a complete 180 in my own care. So, yeah. Thanks.
Who can go to Central City Concern?
We're a federally qualified health center, the health services, and so we don't refuse anyone based on an ability to pay or not. So anybody can go to Central City Concern. Pardon me?
There are capacity issues.
There are capacity issues. However, we're working on that. We're expanding our especially behavioral health services, and the primary care clinic too has an expansion goal in the next couple of years of like a couple thousand people. So, and we're probably going to build onto that building at the corner of Burnside and Broadway. It's 3 stories, but it can take 8 additional floors. So, but does that answer your question? Yeah. Yeah.
I have 2 questions, but I think you partially answered one.
which is about honesty, whether patients are typically honest about suicidal attempts. The other question I have is, have you, when you're talking cross-culturally with patients, are there any issues that come up when you're asking that question about suicide?
Yes. Again, I can only speak from personal experience, but there was a language barrier at one point between me and a clinician. I personally have been to North Africa twice, so I got to speaking Tanzanian, I think. But he just had such a thick accent that I couldn't understand the questions he was asking me. And he got frustrated because you could tell that he really wanted me to understand what it was. And eventually it just ended up with, I think, what do you call it, a warm handoff? Is that they just handed me off to another clinician. And I felt bad because you could tell the guy really was frustrated and he wanted to get through to me. Yeah.
So yeah, language and cultural consultation and translation or interpretation is really important in a clinical setting. We use it pretty liberally. There's a couple of specialty clinics around the city that have multicultural approaches. Up at the university, OHSU has the intercultural clinic, is that what it's, or the international, what is it called? Psychiatric program, right, yeah. So that's a great resource. Yeah, the honesty issue is, it's like, we're trying to be a little bit more enlightened these days, right? So we don't say that people are being dishonest, right? They're probably ambivalent about telling the truth, right? Who here has been ambivalent about telling their primary care doctor the truth? I have. When she asks me every time, why haven't you lost those 15 pounds? And I say to her, I don't know. The truth is, I like to eat sweets. I like, so we try to take that approach. But you do have to always be aware of that. As David said, it may take a bit for someone to really open up and give you the honest information that you need to act. So.
One of the reasons why the default to dishonesty is, you and I have discussed it, is that fear of consequences, right. Where you feel as if I come and I come clean with you and I say, hey, listen, I'm really in a dark place, that I'm not going to get to leave your office. Mm-hmm. I'm going to the hospital. That will cause a person to try to lie or try to cover up their actual feelings, which, that I think that hiding that sort of thing is pretty common.
Yeah, or even worse, you're going to get judged and sent away.
Right.
There's a day in
right.
psychiatry, and especially behavioral health, right? And it spilled over into general health care where we would say to people, go get sober, go get substance free for 3 months, and then come back and talk to us. That was crazy. And that was us, right? So yeah, I think you make a good point. So.
Bridget, I have a question for you. Yeah. Since insurance doesn't cover a lot of the over-the-counters and herbs and supplements that you talked about, what's a good way to talk to clients or patients about quality or the differences in the efficacy of them? Because some of them what? Like go to dollar stores and buy the cheapest they can. That's usually not best.
Yeah, I think I struggle with that conversation as well, because I think it's a fine line, because you don't want to offend somebody, or you don't want to, that's what they can afford. I usually will talk to them more about the medications that we prescribe that have been effective, like our prescription medications. And so from my side, I'm usually telling them, I'm usually discussing what I know about the medications, and I can't tell you if your SAMe or your St. John's wort is going to help improve your depression, but I have some good information that the sertraline can. And I think our clinic is unique with Virginia Garcia and probably Central City being like FQHC, that we have some opportunities for patients for medications that I don't know if other clinics have.
Yes. That's part of the pharmacy clinic, that some don't use our pharmacy.
Yeah.
And I know that fish oil is completely different.
Fish oil is kind of probably the hardest one, because I think I've seen it used for depression, and there's some evidence for it, and so it's usually trying to figure out what they can afford and then asking them to bring in what they're taking and seeing what you can find out about it, because in our system we don't have a great regulation of it, so we don't know. Our problem, well, one issue that comes up in our clinic is we have naturopaths, and so they have chosen to use like a pure product, right? P-U-R-E.
Neighbor's too small.
Oh, no, sorry. We have the pure products, which are naturopaths like very much like have some history with and know like purity wise and what they're great, but they're like $50-$60 a bottle and our patients can't afford them. And so usually I've talked with our naturopath to kind of see like when our patients can't afford these, like what are you recommending? So I don't have a good answer. They're so, try to avoid the dollar store. You can look for like the USP symbol on them, and that's usually what I encourage people to do. And then usually if that's on there, there's some regulation, some, you know, checking to make sure they're good manufacturing practices, which is one step.
And that's a pharmacy.
USP?
Yeah, that's just a pharmacy regulation, not.
It's the manufacturing practices, yeah. Make sure like the facility's clean and they're, that kind of stuff. Yeah.
Going back to the comorbid depression with anxiety, with what you've already talked about, would you more just see the practice of using the adverse or the side effects to your advantage, or is there a whole different sort of approach when there's comorbid anxiety and depression?
The SSRIs have the best advantage or best evidence for anxiety as well as depression. So,
and it's important to know the source of the anxiety.
Yeah.
Anxiety can exist as a comorbid generalized anxiety or panic
Symptom.
disorder or related. In the public setting, if you work in a public health setting, the incidence of trauma is really high, right? And I don't necessarily mean PTSD qualifying trauma. I mean just adverse childhood or developmental experiences, or people in our setting often also, if they have severe behavioral issues and or substance use issues, they've probably been traumatized seeking care. They've either had a traumatic experience in an emergency room or interactions with police or other, law enforcement or, safety enforcement folks. So trauma can look like anxiety, right? The treatment of it is a whole lot different than the treatment of generalized anxiety comorbid with depression. So really the first thing would be to know the source of the anxiety and then target the treatment for that source. Does that make sense? Yeah. How do we treat trauma-related anxiety? Anybody know? There are fortunately some pharmacologic treatments these days, by the way. And fortunately we have a great body of evidence now that says benzodiazepines are the very wrong thing to give to a person with a trauma history with lots of anxiety. They'll want them. If they've tasted them, they'll want them even more. But you have to convince them. The evidence says it will impair your recovery if I give you a benzodiazepine. So now we have clonidine and prazosin being prescribed for specific reasons. And then therapy, right? Cognitive behavioral or dialectical behavioral therapy, proven effective for recovery from trauma. So, one last question.
So, my question is a little broader than the question about how to use a nurse around with mental illness. But how do you feel about internal medicine doctors or general primary care doctors in general managing severe depression or SMI in patients in the clinic alone?
I feel grateful. Most of the time I feel grateful, especially in times of profound deficit that existed like in Oregon, in Portland Metro back in the beginning of this century, like around 2002, 2003. I was enormously grateful. And I ran around consulting and thanking people all that I could. And I also feel conflicted because it's in certain circumstances, it's an undue burden on them, it's an undue burden on the people who we serve. And we need to improve our access in specialty behavioral health for sure. There are models of ways in which we can cross-consult and help improve treatment in place. There are some people with very severe mental illness who, for a variety of reasons, won't or cannot ever get to specialty mental health. So there's models of kind of cross-consultation that are being promoted and researched around the country. But yeah, so my first reaction though is to say that thank you. And thank you to you all too. 'Cause, you know, primary care providers and the team identify and treat, and that's what we're encouraging here, a lot more mental illnesses, and including depression, prescribe many more antidepressants than specialty behavioral health or psychiatric providers ever will. So, anything to add to that?
No, I think, you know, we probably all have very similar experience with our patients with severe mental illness, or our patients that aren't responding to the therapy that primary care can provide, but then not able to get them into a psychiatric provider. So I think, you know, I think we all have been there and are all currently there. And so it's kind of, you know, it's assisting our providers, finding consults and doing things that can help get the best care to the patient with, unfortunately, limited resources to psychiatry.
We're going to wrap things up today, folks, just because we're running a little bit long. But before we do, have a couple closing words today. If you guys wouldn't mind just giving me a big round of applause for all of our